I can confirm that we are now live, Kushni.
Thank you, Tom. Good morning, everybody, and welcome to our public board of our Integrated Care Board for Herefordshire and Worcestershire. This morning I have apologies from Sarah Dugan, Jane Ives and Mark Yates, so we'll note those for the record. We do have a couple of people for whom we haven't yet received formal apologies, so we're hoping they'll be joining us shortly. Declarations of interest. We have a register of interest, but if there are any specific items that colleagues would like to declare an interest for on this agenda, please indicate. Otherwise, we shall note no particular interest for today's agenda. Thank you. So we'll move straight on to our governance log for the meeting, and I'll hand over to Hannah for this. I think there's a couple of actions outstanding, Hannah, that you wanted to update us on.
Yes, thank you, Chair. So the action log would normally contain all our updates against the open actions. So this is not the case today, so apologies for that. We've had slight technical issues. So I'll just provide a verbal update for all those open actions. So the first action, which is a further update on the full recommendations and how the actions for local system deliverables are being achieved. There's an update included in the Chief Exec report on the meeting today, so that action is completed and can be closed. And we'll of course keep providing regular updates against this. We have got the next action is discussion about investment requirements for a long-term sustainable workforce to take place at a future board development session. So this has been included on our long list of sessions for our development for our board. So this has been included in the forward plan, so that action also can be completed. The next action is a stocktake to be undertaken on impact of industrial action, including staff wellbeing and morale. So at the moment, we are in the process of completing staff survey, which is a national survey. The results aren't due to be published until sometime in January. So that stocktake will take place and will include all those findings. There's also a lot of work going on, including a protecting our workforce plan in the context of significant and urgent care pressure. So that will also be included as part of the stocktake. So the proposal is to bring the stocktake to the board in the meeting in March to make sure all those actions have been completed. And finally, there's an action for people and workforce directed to understand primary care freedom to speak up arrangements and ensure that the freedom to speak up and sexual safety work is joined up across the system as a whole. So we are working with the Director of Primary Care of the ICB as well as place leads to put more consistent workforce support in place and ensure that the training hub can provide advice and support on freedom to speak up sexual safety. We're also growing our freedom to speak up system-wide networks, and regular updates are provided to Operational Executive Committee. So that action, I think, could be completed, but we will of course be providing reports to the board via committee reports from Operational Exec Committee.
Okay.
There's nothing else on the governance log, Chair, that I need to bring to the board's attention.
Thank you, Hannah. That's really helpful. Any questions, or is everyone content that we can progress or close those actions as indicated? Yeah. Okay. And I guess also bearing in mind we have the primary care recovery plan on today's agenda, there's a sort of reference to Fuller as part of that, and also of course Katie's workforce strategy update, I think, talks about business cases coming back as required for investment in the future. So I think all of those points link up. Thank you very much. So we will move on to the minutes of the previous meeting. And I just want to check with colleagues. I'm not going to go through it page by page, but are colleagues happy to confirm their approval of the minutes as they stand? Vicky.
Hi, sorry, it was just a point on accuracy, just on page 10 of 20. I think they meant VM, not VW. Just
okay,
from a personal
Vicky.
point of view, that was.
Yes, unless you've changed your name in the meantime, I think we can make that change, isn't it? So page 10, Yeah, VW, okay, QRD, the reference to QRD, which is the Quality Resources and Delivery Committee. So it's the bottom paragraph of page 10. So we'll note that correction to the minutes. Thank you, Vicky. Any other points of accuracy or matters arising? Okay, thank you. So we'll take those minutes as approved, apart from the minor change required on that, the initials that Vicky has highlighted. We move on then to questions from the public, which is part of our patient and public voice section. So just to record here for the minutes that we received a letter from the Stroke Association, I think it was several weeks ago now, and because of the timeline for the letter being received, there was a formal response provided, which is quite a comprehensive letter. That letter has been circulated to board members, I believe, today. But also just to say, because it's quite an extensive letter and response, we're not going to take the time to read it out at the board, but we will associate it, a link to it with our minutes so that it is in the public domain. And any member of the public can reference the full response that was sent to the Stroke Association. So thank you to colleagues there for the question that they submitted, and we obviously will continue to encourage members of the public and other organisations who may have an interest in what we're doing to submit any future questions, which we'd be pleased to respond to. So on that note, I shall pass on to Dr. Catherine Cobain for our patient story, please.
Thank you, Chair, and good morning, everybody. Inequitable access to healthcare can result in particular groups receiving less care relative to their needs, or more inappropriate or suboptimal care than others, which leads to poor experience, outcomes, and health status. This patient experience focuses on health inequalities and how a personalised approach can make a world of difference. I will refer to the individual as Carl to protect their anonymity. Carl is in his late 40s and has been sofa surfing around the area for a number of years and has had limited engagement with health services over this time. Carl had found it difficult to engage with the homeless drop-in GP service at the day service that he attended. He was unable to read and write and therefore had difficulty accessing information. Carl had unstable diabetes. This was type 2 diabetes, but which he'd had for a number of years, and had become insulin dependent with poor general health. He had experienced and been admitted to hospital as an emergency in the recent past due to high blood sugars. Your Health Service is an outreach service that uses a mobile vehicle to go to people in their usual environments. The service targets its delivery in areas of higher deprivation where people are more at risk of being underserved. Your Health Service aims to deliver key checks to identify unrecognised health need and support people to engage with services, including registering people with a GP practice, if not already registered. Carl engaged with an advanced nurse practitioner working for Your Health Service through the MAGS Day Centre. This led Carl to being identified as having a previously unrecognised learning disability. Reasonable adjustments were also importantly recognised with a personalised approach with regular contact implemented to build trust. Carl was treated for a chest infection and his diabetes was stabilised. He started to feel better in himself following this. He was also supported in gaining accommodation and registering with a GP practice to enable ongoing health monitoring and appropriate intervention. In addition, referrals were made to other support services, including the Learning Disability Community Team. I'd like to say in Carl's words the outcome of this engagement. I have diabetes and insulin that the nurse helped me with. I am so happy with all that she has done. I'd be nowhere without her. I'm grateful for it. Carl also stated when asked if he would have sought help for his chest infection or deterioration in health. No, I wouldn't be here by now. The advanced nurse practitioner advised that Carl would not have consented to sharing his experience at the beginning of their relationship. His trust in healthcare has improved so much that he is willing to allow his story to be shared with you all today. So a couple of learning points on this. This experience highlights the importance of taking a personalised approach to responding to underserved groups. This can help build vital trust and develop sustainable engagement with mainstream services. Your health service will be subject to a qualitative evaluation by the University of Worcester. This will enable experience-led plan, do, study, act, which is an improvement methodology cycle, to understand if the service is narrowing gaps in access for underserved communities. Thank you, Chair.
Thank you very much, Kath. Obviously very pertinent to our deep dive today, which is all about health inequality. So really, as we've always tried to do, sort of link our patient story to the deep dive that we're doing today. So a really powerful example of the difference we can make if we reach out to people who maybe need access to our services, but who are perhaps reluctant for different reasons. So I think it really enforces sort of trusted people, trusted places concept that is often talked about. Any thoughts, comments anyone would like to make before we move on from that? Nigel?
Thank you. Yeah, and I think it's a very powerful story. I think it's really timely as well. I think the issue about inequalities versus inequity is really important, and I think sometimes as leaders we need to be absolutely sure that sometimes some of our services which produce good numbers, we've got to really drill down to make sure that actually some of these services which target some of the most difficult to reach people don't look like they're very productive services, but because it requires quite a lot of effort. And in fact, I know in Herefordshire, when we've repurposed some of the health check contracts, that in fact numbers drop, but actually we're getting more penetration into the people who probably need it most. And I think that's really, really important, that sometimes it's not just a total numbers game, because some of those people would come and see us anyway. It's actually targeting it to the right people. And I think that point about trust is really important as well. I think we've got to remember that trust is really a social determinant of health, and actually developing trust with all members of our society is really, really important.
Thank you very much, Nigel. Okay, Vicky. Oh, hang on. Let me just make sure, because the numbering system these days. Sarah next, I think, actually. Well, the numbers change just to confuse you.
Thanks. I was just really interested, Kath, in that story. I mean, great that the trust has been built up and we can have the story shared. The comment you made about an undiagnosed learning disability, I think that's really important to highlight. I think when we're looking at health inequalities, there are a cohort of people who either have moved into the area or who might not have had such engagement with schools, and we don't have that information. And if they're not registered with the GP, that's something that gets lost when you leave school. No one else holds that information. And sometimes it's quite difficult to get people diagnosed and into the right services in adult life. So I do think that that's something for us to be mindful of, and to perhaps think about a little bit about how easier to transfer people's educational healthcare plans when they are registered with a GP, and perhaps the GP to hold that information so it transfers into adult life. But actually it is a real gap for people who don't keep the bits of paper with their diagnosis from when they were at school or not at school, and then are left as adults in real difficulty. So I think it's a societal gap, but it's one for us to think about a little bit as well.
Thank you very much, Sarah. Vicky?
Thank you. Kath, I just wanted to ask what the timescale for the university review of this project was, because obviously the positive impact of this patient story is fantastic, but it'd be great to understand the wider impacts of this. And to Nigel's points, I guess, is that review going to include patient-related outcome measures so that that personalised outcome is tracked through?
Kath, do you want to come in on that specific point?
I don't know if David might want to come in, because he is obviously he's more leading in this area. Like my understanding of it is that there'll be a proper evaluation, because this is a new service, so a proper evaluation to make sure that what we are doing, because what we're doing is new, is actually working and is doing those things, is improving those patient outcome measures that Vicky refers to. But I'm sure David will probably draw on that within his presentation later.
Thanks, David. Should we come back to that as part of the deep dive then?
Well, I mean, I don't think there's much more to say actually, Christian, other than that the evaluation was commissioned and funded as part of the funding for the programme, and will obviously be undertaken during the course of the early phases and then formally written up later on. I'd have to check the exact date, which I can report back to Vicky separately.
Okay, thank you, David. I do think the point that Nigel made, that Vicky also referred to, is an important one around you know, is the additional cost sort of proportionate to an additional outcome that the sort of, there's something about proportionality, isn't there? That there could be very powerful outcomes for some individuals which the cost might justify, and therefore traditional productivity type measures might not really pick that up. So it's sort of real value added, I think, sometimes, which particularly when it comes to health inequalities, I think it is going to be really important. So perhaps we could just think about that, as colleagues have said in the evaluation. Okay, and finally, Graham.
Thanks, Krishni. I don't know technically enough about how the records work, but I'm just interested, if someone has been identified as having some specific access requirements or needs, is that shared amongst all the system stakeholders to prevent someone going through the same story again and again?
Good question, Graham. Any volunteers for who feels able to respond to that?
I can start with it, Chair. It's a great question, Graham. And you know, I can talk about it in the learning disabilities field specifically, because we have digital flags that are placed on, so that people know and are able to be recalled and called and recalled. But I do, you know, and also for children who are looked after and things like that there. But it's not there is more work to be done, I think, to make sure that we're doing that sort of universally across. But I don't know if anybody wants to add any further from their experience.
Any other comments or thoughts on that before we move on, David?
Well, just to flag the fact we've got the shared care record, and information like that is available to all providers through that digital platform that we've created over the last few years.
Thank you, David. Nigel?
Yeah, I think it's an excellent question, and I think to be brutally honest, we haven't been as good as we should have been in the past about sharing this data. I think things like the shared care record are a step forward, but I think we do need to be more mindful. I think that we might touch on it as part of the primary care recovery program, GP Access, but actually sometimes segmentation and identifying patients and being very clear in regard to those that require continuity and require particular services is going to be really important. So I think more work to be done. I think there are some digital solutions which are helping, but I think we've got to keep the pressure up, and we've got to make sure that there is not a divide between clinical systems within Herefordshire and Worcestershire.
Thank you, Nigel. Yeah, I mean, I think it's an area, if you often speak to patients, about their experience of healthcare services in all sorts of different settings. So they'll say one of the frustrating things is having to repeat their story and over and over again to almost every clinician that they encounter, and that can feel really frustrating, because I think, you know, for all of us who've been there as patients, we probably get frustrated because you think, well, I thought I'd filled that out on the form. The number of times I think that in my head, I thought I said all of this. Why do I have to go through all this again? So I think there's something about trusted assessment as well, and it's perhaps something that clinicians are better able to comment on than I. But I do sometimes think that because of that sort of sense of, you know, each clinical service, you know, perhaps work in a slightly siloed way, we don't then engender this sense of trusted assessment between services as easily as perhaps we should. So Will might be able to comment that or dispute that.
I think it basically comes back to the piece we've been doing around Fuller. You know, the team of teams working cross-organisationally across professions in a neighbourhood is really the model that we have signed up to, and actually will enable those conversations, that joined up way of working where you don't lose people at the interfaces. And that's absolutely a priority for us to try and get on the ground, which should help all of this. So I think it's really emphasises why that's so key.
Thank you very much, Will, and helpfully, you know, we can, well, perhaps all of the items on our agenda today, to some degree or other, sort of touch on this, don't they? So, Nigel, final comment?
Yeah, I just leading on from your points, Krishni, I think actually that story about telling your story once, I think that is really important. I think, you know, assessing that as we work through our integration journey is going to be really important. That may be something we want to hold on to as a marker of how successful we are, actually, because if people are having to tell their story multiple times still, then we have failed in our integrated care journey. So I think that is a really useful thing.
Thanks, Nigel. So yeah, let's have that as an aspiration for the kind of level of integration that we're looking for. So thank you very much, everybody, and thank you, Kath, for bringing us that story, which I think sets a really good context for today's meeting. So we move on now to our updates, strategic updates, and first and foremost, we've got the report from Simon, please. Over to you, Simon.
Thanks, Krishni, and hi everybody. I'm Simon Trickett, Chief Executive, so hopefully you've all had a chance to read the report. I'm conscious we've got a long agenda today, so I wasn't going to spend ages introducing various aspects, but just to draw out 3 bits in particular. So firstly, the start of the report describes a series of changes that will happen over the coming weeks to the board memberships. It would be remiss of us not to acknowledge Graham Hodgins' contribution over many, many years, both Herefordshire CCG, Herefordshire and Worcestershire CCG, and then Graham's been a key part of helping us to manage the transition into the ICB. A man has been working alongside him for much of the last 18 months, and a man will take over that role fully from the 1st of January when Graham leaves us. But a big thank you to Graham on behalf of everybody for all of his work and efforts. The report does describe another couple of changes. So we have a partner member vacancy, which is Matthew Hopkins' previous role. We will be making arrangements to fill that vacancy on the board over the coming weeks. And we are also, I think it's tomorrow, Krishni, isn't it? The interviews are taking place for the new non-executive, Friday, sorry, yeah, the new non-executive member for finance that we've added to our arsenal of weaponry, if you like, as a board to tackle the issues that we've got to do. So a few board changes to come. Also to point out on page 3, I describe a series of actions that are taking place looking forward to next year's planning process. It would be remiss of me not to mention some pretty significant developments to the in-year planning process that happened last week after we published the report. So you may have read in some of the health service press about some additional funding that the Department of Health and Social Care had made available to systems. basically to try and cover some of the excess costs that have been incurred this year because of industrial action. I think it's covered in more detail in Mark's report later, but obviously we have a number of things that have made delivery of this year's plans pretty difficult. Industrial action costs are one of them, but also obviously inflation has been running for most of the year at a much higher level than we had planned for. So a series of impacts on the in-year plan and a lot of work to do actually to clarify where we are in terms of in-year delivery. And board members will be aware we're going to have a briefing session after this meeting to try and bring you up to speed with the detail. But just to flag, there's a lot of work going on looking ahead to next year, which is described in the report, but subsequent to the paper being written, we've also got quite a bit of in-year work to do as well, which is important. Then the final point, Krishni, I would just highlight on page 4, we have the early results of our point prevalence audit that were repeated again in September. So we studied 1,700 patients across our system in 93 care settings. And interestingly, we have now a benchmark, obviously, because it repeats the exercise we did last year. So one of the key things we're looking at are what are the changes that have happened since the last audit that we did. You'll see some improvements in Worcestershire in terms of people not being in the right place for care, and a little bit of deterioration in Herefordshire. But I would say there's a lot of work going on with Paul and teams around how we organise and deploy a lot of those resources in the Herefordshire system. And Jane Ives, if she was here, would describe quite a detailed piece of work that's now taking place to try and make those improvements. So we'll continue to analyse the audits, we'll continue to work with the operational teams to share the learning, and we're committed to repeating this on an annual basis, as we've said before, because it's a really good insight into how we're getting on, what's happening in the system, and probably most importantly, what impact some of the initiatives and programmes we're running, what impact they're having. So, Krishni, I'll leave it there in terms of introduction, but happy to take any questions.
Colleagues, any questions or comments on the report as usual? So first of all, bring in David Whiteman.
Thanks, Krishni, and thanks for the report, Simon. Just a couple of questions about the emergency new ED opening at Worcester Acute and also the Home for Lunch campaign. Do we have any initial indications of whether things are improving through the ED opening at Worcester and also through the Home for Lunch campaign?
Yeah, good question, David. I mean, I think the ED opening, as we've said before, it's a complicated picture. A shiny new ED department is great, but actually our focus has been on, and the focus of Russell and the teams in the hospital has been on everything that happens behind ED, and in particular, and I think I allude to it in the report, the relationship between the various specialties and teams in the hospital and ED and their interface and how they support each other. That's really where we're focused. The new ED is a much improved environment for patients, and actually we saw in the early weeks of opening some improvements in performance. I think it's been a bit mixed. We had a problem then a couple of weeks ago. This week's been better, so there are some early signs of progress, but there's a lot of work to do, and a lot of the work we're focused on is all really behind ED and what happens after that point. I think the Home for Lunch campaign that we've only been running for a couple of weeks, I was asking earlier, and Ashleen told me we were typically discharging about 15% of people before 12 o'clock, and last week it was up to nearly 30%. So some really good early signs of an impact of that, but we clearly have got a long way to go. We need that embedding. 1 week's good performance is great, but it needs to be maintained over a longer period of time. So we're hopeful, I'm hopeful that we're doing all the right things. We understand the scale of the challenge. We're right alongside the new leadership team in the hospital, and we're helping and supporting to try and embed changes for the long term really, and not kind of flash in the pan short-term benefits.
Thank you.
Thank you very much, David. Paul Walker, please.
Thank you, Chair. Firstly, apologies for my late arrival this morning, but I could catch up with progress so far, and thank you to Simon for the report. I just had a couple of things, and probably not surprising, just wanted to pick up on children's services. And yes, 3 Ofsted visits in the last 6 months has been kind of quite an imposing pressure on the service at a time when we need to focus on delivery and improvement, but come through those 3. And as Simon's alluded to, looking forward to making further progress. We've also just come through the 6-month review with the Children's Commissioner, and a formal meeting was held last Monday, and recommendations have gone off to the Minister for approval. But the Commission is pretty clear that given the progress that's been made and the trajectory of improvements, that the issue of should we look at an alternative delivery model for children's services is no longer a question. And she's quite clearly recommending to the Minister that children's services should remain in the operational control of the local authority, which is good and positive news for all of us who are involved in supporting those improvements. There is a kind of a common theme that comes through Ofsted and the Commissioner's report, is not just about recognising improvements and change that have been made, not least in the MASH and the Children with Disabilities team, but there is a fundamental challenge around the pace of change and how we can work collaborative to impact on that. I think that just picks up on the recent health summit that was held, was a real opportunity to bring people together and to kind of invest in relationships at all levels, both tactical, operational and strategic. And whilst we've got 3 immediate priorities to focus on, it is very much around how can we use those as an opportunity to accelerate the pace of change. And Simon and I have talked separately recently about investing some further time and energy in developing relationships at a strategic level with myself and Simon and our immediate directors, to kind of look at where it is we can have our greatest impact across the system, and how do we do that. So I'm pleased about that, and I'm pleased about performance there. And secondly, I just wanted to ask a little bit cheekily about dentistry, and the quite an attractive number of additional units coming in Q1 of 2024. I just wonder whether you might allude to that. It's quite a slimline paragraph, and is there anything further to add?
Yeah, thanks, Paul. I mean, we have reported it previously, and you always need to be cautious in these reports, not to just keep saying the same thing over and over again. So that's why it's a slim line, because we did put quite a bit of detail in last time. But look, that's a massive development for Herefordshire dental access. There really is no NHS dental access to speak of at the moment in Herefordshire. Those 2 contracts are massive, really, but we obviously need to make sure they're implemented in the right way, and that we work with the new providers to bed in a new model, and critically to make sure the right people get access as well, because there is a big kind of reducing health inequalities element to this. And then with dentistry, the plan is to use those new models, because what we've done is we've been quite creative with the contracting mechanisms, and we'll be looking to use those creative contracting mechanisms both to drive hopefully further additional access across Herefordshire, because both of those new practices are situated in Hereford, one north of the river, one south of the river, and obviously it's a big county and we need to get better reach. But also we've got some big hotspots in Worcestershire, so Evesham in particular keeps being drawn to my attention through my postbag as being a particularly poor area for access to dentistry. So it's going to be a long journey recovering that dental access thing. It's a great start, and it's great for you guys, and lots of your members will be interested because lots of them write letters to me. So I know that it will have a big impact, but we're confident that's going to make a big difference. Just Paul, on the children's services, I think it's worth reflecting. We had a good conversation at Worcestershire Health and Wellbeing Board yesterday, because they've been on a similar journey to you, and it's the further we've got into that journey, the easier it is to reflect on the impact. And I think regulatory intervention and focus, actually what happens in the first instance is it creates a whole new demand, doesn't it? We end up sucking more and more children into the system. And firstly, as an ICB and then as a health and care system, we have to recognise that additional demand is there. So in our planning, we know we're going to have to increase the resourcing for some of the children's health services to keep up with the improvements that have been made by Paul and colleagues. But we're in this for the long run, aren't we, as well? This isn't going to be a quick fix. 3 inspections in 6 months. There's plenty more inspections to come, aren't there, unfortunately, and we need to stick together and keep focused on doing the right things and making sure we've got the right prioritization of this work, because that's what we can do to correct some of the issues that have been addressed. So we're going to keep talking about children's services, I'm sure, at every meeting, just like we'll probably keep referring to dentistry as well. So 2 good points.
All right, thanks, Simon. Thank you.
Thanks, Paul, for the questions. Graham is next on my list. I think you were on the list, but you've disappeared. So people just need to be aware that if you're waiting for a while, your hand automatically gets lowered, and you have to keep it up. So just to make you aware, in case you want to come back in. Aman, did you want to ask a question?
My question was going to be around the children's services, so I think Paul's answered that. To be fair.
Great. That's great. Thank you, Graham.
Yeah, thanks, Krishni. As ever, Simon, a great report. And I've got to say, I was really thrilled to read about the developments with the 3 counties medical school. I think that's a real step forward. The thing that did pique my interest a little bit was on the immunisation programme. And as a non-clinician, I got to say, I was really surprised at the low uptake of some of the frontline staff on flu and COVID. And I'm just wondering, is that something specific to any of our stakeholders, the system, or is that a national picture?
Yes, Graham, it's very much a national picture. And in fact, we benchmark really quite well, even with that low figure, which is a concern and a worry, isn't it? I think there's a whole host of factors that might be behind that. But the issue is we've got to refocus and redouble our efforts on making sure staff have good access to that protection of the immunisation, and that we're encouraging them to do it. We're back probably into the rhythm and routine that we had pre-COVID, where this was always quite hard work to encourage staff to take a minute to have the vaccination. People are so busy, so we're going to be going around that loop a few times, I think. I mean, the public vaccination figures for the at-risk groups are really impressive, but the staff, we've got a long way to go with staff, and we'll keep working on that.
Thank you, Graham. David. David Whiteman, sorry.
Sorry, and I'm also on mute as well. Apologies. I wanted to welcome the section on strategic and operational planning, because that is really showing the kind of outworking of the ICS in practice. I wanted to kind of applaud the fact that we're really now working together as a system, putting together longer term operational aims, and also to ask for assurance that when we look at the agreed priorities, 1, 2, 3, 4, 5, 6, 7 of those, presumably as we work into those over the planning cycle, we will be able to put in measurable targets for those. It's great to have priority areas, but I think it's important for us to have measurable targets on those as well.
Yes, David, I agree entirely. I think the couple of things I'd add are, firstly, it does look like next year is going to be a really hard year financially for a whole host of reasons, not least of which it's the last year of the comprehensive spending review settlement, and there'll be a little bit of political uncertainty as to what our new government will do, and there will be a new government before the end of next year. So those years are always difficult. And the point I'd make about planning, you're right, we've got to be clear on the measurable impact of our interventions. We're trying to make a bit of a subtle shift for next year. What we've traditionally done, which is really good management practice, is a very bottom-up approach to planning. And even within the providers, teams and divisions will do their plan. This is what we can do. This is what we'll need. This is how much it will cost. And woe betide, what has been happening is you then add all that up at system level, and it's totally unaffordable, and it doesn't meet some of the system objectives because people, divisions and teams focus on their own stuff. So the key shift we're trying to make this year is to introduce a bit more of a balance between top-down leadership of that and the priorities are meant to set and frame a bit more of this is what we're looking for, and we're trying to extend that to and broadly, these are the resources that are going to be available for your area. So the question for teams then becomes, these are your priorities, this is broadly your resource envelope, come back to us and tell us how you can organise yourself to deliver that, which is, it's a subtle shift, but it's quite a big mindset shift, and it is driven by, we can only do that by working as a system, and Emily Godfrey and the team are working really hard to reframe this and reset it a bit. So I suspect it might be a bit of a bumpy journey over the coming months, but we're certainly setting out to try and do this quite differently than we have done in more recent years.
Thank you.
Thank you. Thank you, Simon. Nigel?
Yeah, just a quick view on the vaccination of staff. I know that we had quite a lot of COVID infection amongst our staff, probably in the preceding month to the start of the programme, which then probably precluded in my practice about 50% of the clinicians having it on time because they couldn't have it because of that previous infection. So I think that we need to keep the window open because there may be a slower uptake, but for quite understandable reasons. I think it's just a factor we need to just be mindful of.
Yeah, thank you, Nigel. And certainly from my experience in elsewhere, I think it's been much harder getting flu vaccination uptake alongside COVID. I think for some groups, perhaps there's a lot of a bit of vaccination fatigue, I guess, over a period of time. So I know there's been a real challenge, you know, in some organisations, I think particularly community services and others to get those uptake levels higher. So it is something, as Nigel and others have said, we need to continue to focus on. It's a really good report, so thank you, Simon. I think I just wanted to comment on, I've shared this with Simon already, but I do very much welcome our Home for Lunch campaign. I think there's been, you know, it's a really, it's quite an eye-catching campaign if you haven't seen some of the material, but I have shared that nationally with the other chairs actually, and a couple of people were very interested in what we were doing, because I think there's a general sense about the importance of communicating with the public about what we need from them to help us as well. And I think the Home for Lunch campaign is a really good example of that. So just wanted to commend that. Really also wanted to welcome the frailty strategy, which I know has been agreed now. I did wonder, and I don't know if this is practical, but it would be really, I'm always quite keen with strategies to think of easy ways of communicating these things so that they don't become like huge strategies with big documents, but actually are very easy to understand and follow. So I don't know whether we have any plans around communicating our strategy, which I was just wondering about, because I do think it's important for everybody to understand what it is. So any thoughts from Simon or Mary or Will about, you know, how do we want to kind of get people to really buy in and engage with it, so it isn't just a document sitting on a shelf?
I mean, I can come in. Look, we the last thing we ever want to be is an organisation that produces glossy strategies, and there's a cupboard in the corner of my office that they could all rest on, but if they don't really mean anything to anybody, then it's pointless. So describing and what impact we intend to have with that strategy is the sole focus, Krishni, to be totally honest. So David's done a lot of work to get like a consistent way of presenting strategies in a pretty straightforward way, but then the action plan and then the communication of the action plan are absolutely essential next steps. So that's where mine and Mary's management time is focused on, and actually it's quite a place-based delivery model for the elements of the frailty strategy, but being able to be clear on those and then being able to tell the story around them are really, really important. Maybe we'll make a note to talk about that a bit more in the January report. We can describe a bit more about the detail of what it means, what's going to change as a result of this, and we can describe the communications plan for that as well. Good suggestion.
Lovely. Thanks, Simon. That's really helpful. Russell.
Krishna, I just wanted to segue back for a second to the Home Before Lunch campaign, as this is a public meeting and hopefully members of the public will enjoy watching it. The evidence for hospital-acquired functional or physical decline and hospital-acquired emotional decline in terms of decision making is really quite overwhelming, that when the acute setting has been fulfilled in terms of your medical clinical needs, the best place for you to be is at home. And we need to get that message across in terms of expectations management to the patients and the families we look after, that when we're encouraging to find a way to get your loved one home or you home, it's because it's in your best physical and emotional interests. And equally for our clinical staff, helping all of them to understand that extensive length of stays, which we do see in our system in some places, and I know I'm ultimately responsible for that, but we do need our clinical staff to truly engage in that overwhelming evidence and help the discharge process. If we do that, flow will improve, length of stay will come down, we'll have more bed capacity, we're able to be more productive, see more people, drive down the waiting lists. I can't emphasise enough, the Home for Lunch banner is really all about flow and that it's right for the patients and their families. So I just wanted in this public forum to emphasise that. Thank you.
Thank you, Russell. We would all absolutely endorse that. I think it's, you know, it's really important for our patients and our community, and equally, you know, very valuable, I think, for our staff and our services. So it's a real win-win, and that's why I think it's a really positive campaign. So really important message. Thank you very much. So Simon, thank you for your report. We'll note that. I think there's nothing that you particularly needed us to approve as part of this report. So it's really there as a broader update on a variety of things. Actually, just because I think it'll flow better, I'm going to move us on, if it's all right, David, to the primary care access and recovery plan, because I think our committee escalation reports are a little bit early in the agenda. I'd quite like to continue to focus on some of the strategy areas. Is that all right, David, or would that cause a problem for you if we go on?
No, that's fine. The only logistical issue is we're dialing Linda in to join and answer any questions. So I will prevaricate for a little bit while Linda joins, just to give time.
Okay, Linda's with us. Okay. So
I'm going to introduce this item, Krishni, and Linda's joined to answer any questions, but also worth reminding folks that we've got 4 GPs on the board as well. So I'm sure they'll have a view on this particular issue. So this plan is a product of hard work from Linda and the primary care team, because we know that primary care is a big issue nationally for government and the public. There can be a perception that primary care is inaccessible, which just simply isn't true. I mean, our practices now provide more than 500,000 appointments into primary care per month, and that's 100,000 more than before the pandemic. And in overall terms, when we compare ourselves to other practices or other ICBs up and down the country, access to primary care is good in Herefordshire and Worcestershire. So in the 2023 most recent results, it was better than the national average, quite considerably better than the national average, and typically in the top 10 to 15% of ICSs in England. However, and it is a big however, there's significant variation between those practices that provide the best access to the patients and those that provide the worst access to patients. And tackling that variation is a really critical component of this primary care access recovery plan. So this plan itself, which board members had 2 weeks ago, and we gave plenty of time to read it because we recognise it's a very important document and a very meaty document, is a response to the national plan that was published in May 2023. And it aims to address 2 key points for primary care, and that's about growing demand and workload, so the kind of pressure on the system and how we can manage that system, and also the decreasing public satisfaction with access to primary care. So the plan itself's been developed in conjunction with our practices and our PCNs, and it's been through a pretty robust engagement exercise with local partners, stakeholders, place-based groups, and both health watch bodies. So I'm not going to go through the plan in detail because board members, as I said, have had 2 weeks to look at it, and it did have a good airing at SCC last week where we went through the detail of it. So at this point, I think it's probably best to just pause, open up for any questions, and then ask the board to sort of note the plan and endorse it. Just to be clear, the board isn't necessarily been asked to approve the plan. NHS England have just asked that the plans are discussed in the public forum.
Thank you, David. And I think there's a requirement also to bring it back to the March meeting. I think you might have mentioned.
Yes.
And it's probably worth saying as a bit of context, really, that primary care is an area of sort of quite big national focus, certainly as whenever I engage with Richard Meddings as NHS England chair, it's almost always quite, top of the agenda, because I think, access to primary care is seen as very important, I think, to our population, absolutely understandably. Let's open it up to questions, as David has suggested. So Russell first, please.
Just a perspective rather than necessarily a question, Christian. I commend this. I think it's a really good document, and I think we should all, as citizens of Hereford and Worcester, be proud of the primary care services we provide. We invest more than many other ICBs in our primary care colleagues, and I think we get value for money, as demonstrated by David's comments about the 25% increase in appointments. I would just encourage that even with this plan and with all the good stuff that's going on, with the combination of an ageing population, an increasingly obese population and an increasingly emotionally fragile population, we are going to still be overwhelmed by demand. So I'd like to see a sister document come to us on our prevention strategy, and to be able to see that we are truly investing in prevention to try and change the dials of these enormous demographic and societal increases in demand we're seeing. Certainly one of the things we're doing in the foundation group is for every business case we sign off now, we have to have an element to talk about our work on prevention, because we do feel that despite all of the good work that we're doing, unless we get all of our citizens to work together and in communities to self-manage, to eat less, move more, look after one another, help with volunteering on issues like loneliness, we will still be overwhelmed despite all the good work in this document. But I commend the document. Thank you, David and team.
Thank you very much, Russell. David, do you want to pick that up as part of the later item, or do you want to comment on that now?
Probably worth just making a quick comment now that, it's great to hear what you're doing within your group providers there, Russell, because of course the joint forward plan, the headline of the joint forward plan was making a shift upstream to prevention. So to see that translating into practical implementable actions in trust is fantastic, because it's demonstrating that we're getting grip on that. The other thing I would just reference is, of course, we're in the process of finalising the strategic demand and capacity model to look forward over the next 5 and 10 years. And we know we've modelled in detail the growth that we're facing and the impact of the demand that Russell describes there. What we're currently finalising is the impact of the mitigations that we have already described in our plans, and the extent to which we're going to be left with a gap to close at the end of that process. So there's that piece of work that is also relevant to this, but clearly much more work to do to get prevention truly embedded in everything we do, and not just a kind of an aspiration.
Yeah, thank you, and it's a really important point, isn't it, which I'm sure we would all acknowledge. Vicky, please.
Thank you. I just wanted to ask about the, from the workforce point of view, it's very clear about the alternative pathways within the GP practices. But what I couldn't see, and I know there was some really positive movement in terms of GP recruitment, but also pharmacy, because it obviously referenced some of the challenge with the resource around pharmacy, whilst it is an alternative pathway. So I just wondered, perhaps Katie, because I couldn't see it in the workforce report, but I might have missed it, so apologies, whether there is the combination of a national recruitment drive, you know, plus then the local recruitment drive around those two particular areas.
Shall I come in there, Chair? Thank you.
Yes, please.
Yes, we are. I'm working closely with Linda and Primary Care and the Training Hub to look at what we need to do locally to make sure we do have the right workforce in place. There's a little bit referenced in the workforce report, just a small paragraph, because I've not given you a huge amount of detail on today's position in that. But we'll be bringing that through QRD regularly, and we'll give you the detailed proposals that we've got around how we're going to bring in more, particularly GP partners and other roles into practices.
Thank you, Katie.
Thank you. Nigel, please.
Yeah, thank you for this report. I thought I'd just perhaps add a bit of perspective, if that's okay. I think yes, our access has been good, but I think it could be smarter. And I think that's, you know, and we need to, as has been said, reduce the variation. So I think that's very clear. I think the smarter bit is not about stressing frontline services more. In fact, you know, we cannot just continually ask our frontline staff to do more and more. It's not about that. And I think that needs to be very clear. This is about doing things like having really joined up websites. This is about digital first, digital triage, which improves efficiency and reduces clinical time spent in sorting and managing our patients. So I think, and that's working smarter, not harder necessarily. So I think that's really valuable. I think we need to be mindful, though, that when we make these changes, particularly if we're looking at digital first, there's quite often an 18-month lag. So in patient satisfaction, only because of change and new ways of working. So I think we just need to be mindful that instantly people don't necessarily see the benefit, but they do ultimately. And there's really good evidence that actually patient satisfaction rises really quite quickly once people are used to new ways of access. And I think there's something about that as well with our new roles, as has been alluded to with Vicky, you know, actually being signposted to these first. Sometimes people find that a bit unusual and expect perhaps to see the GP first, but actually we just need to normalise that as being actually that's a really positive thing. You're seeing a specialist in a particular area and you've been signposted there, and it's working well. So I think that just needs to be clear. Yeah, and I think in particularly just in response to Vicky about pharmacy, we've been very successful actually in Herefordshire recruiting pharmacists into general practice. We've just got to be a bit careful that we don't strip them out of secondary care. So we've had a little bit of a delay in our recruitment from where we would want to be, possibly because we don't want to destabilise the hospital departments. So there is a bit of just management that needs to go around that. Thank you.
Thank you, Nigel. Really helpful. I think we would. I'm sure we'd all endorse those points. Aman?
Thanks, Krishni. Just want to say this is really good piece of work and really supportive. Just one of my questions was around patient choice. How does this impact patient choice? Because I'm just thinking about, so I think there needs to be this educational piece. I'm just thinking about my own dad, you know, he refuses to see anyone other than a GP. So how do we, you know, educate our community in terms of, you know, and I think Nigel touched on it already, but I just want to know how we're going to do that, because I know we've done like patient participation groups and what, but those are normally the engaged patients that participate in that. So I just want some assurance as to, you know, how we're going to work with the community to ensure that they know that this is a positive thing.
Can I come in on that?
Yes, please do, Linda.
It's a really good question, Alan, and you see throughout the plan we're focusing on two things. There's the delivery of the national requirement, but really important to GPs and patients is that continuity of care. And so while we're implementing digital first and other miss out on continuity of care and practices understanding and recognising those patients who need to see the same person more often. Throughout the primary care access capacity plans, which is on page 13 of the plan, you will see that there's a huge amount of work going on currently between Healthwatch and the PCNs. Healthwatch are providing valuable input to PCNs on how their PPG groups could reflect more the population that the practice and the PCN is serving. Only one other example I'd like to give of innovation and what practices PCNs are doing differently is around communicating more via parish magazines, for example, and receptionists in particular and other members of the practice staff now sitting in the waiting room, talking to patients, showing them how to use digital, but also explaining the changes in practice, and all of those things come together. Just doing the one thing wouldn't be as effective. So I hope that answers the question.
Thank you, Linda. Simon, please.
Yeah, thanks, David and Linda. I just wanted the opportunity to draw out this focus on variation. So we know the overall picture is really quite reasonable when compared to every other system, but I think we increasingly are aware of, in lots of PCNs, there's some practices that have had fantastic access and some where actually there is a lot of room for improvement. So that focus on the variation, levelling up to the higher performers, and actually increasingly PCNs and clinical leaders locally owning the understanding of that variation and supporting their peers to make the improvements they need to make. I want the board to understand what a big part of our plan that is, and it comes across in the document, but I think we should draw that out, because for me, levelling upwards, managing and owning that variation, if we get that right, that probably is almost the missing piece of the jigsaw, because whilst GP access is pretty good, we do still get a lot of noise. I get a lot of letters, Linda gets a lot of letters. We are not doing as good a job as we can do for some patients of some practices. So that focus on managing that variation is going to be a big part of this access recovery plan for us.
Thanks, Simon. And I think I was going to reinforce the point. You know, I think clearly we've got some really good results, but equally the national average isn't very good to start with on some things, like percentage of patients reporting that it was easy to get through the GP practice by telephone. 50% isn't great, is it? I'm sure we'd all want it to be better nationally, and even our performance at 56, albeit better than the national average, I would have thought we'd all want that to feel better. So I think, and the probably the variation demonstrates that actually if we could really address some of the practices where the variation or the performance isn't so good, actually we could make a big difference to the overall figures. By the look of it, that's my sense anyway from reading the data. It could be a really big impact that we have going forward by focusing on that. So I do want to just reinforce the importance, I think, of that. Sarah, please.
It was just quickly really to reinforce, I guess, in the space of this being a public facing meeting, that in our SCC, our Strategic Commissioning Committee, we did look at this in detail there, and Linda presented, and one of the things that I think is worth highlighting, and it does come through in the paper, is that whilst there are clear national standards and a national framework to follow, we've got a lot of local nuance in this plan based on local public engagement, local clinician engagement, and I just think that's really powerful. And it loops back to a point that Nigel made in a previous item about trust. We know that GPs are really trusted healthcare NHS professionals, and when people do surveys, and actually it's not eroding that trust with the public. The GP is still there for undifferentiated illness when you don't know what's wrong, but that drive towards self-referral when people do know what's wrong, and we've got a nice list there in the paper of things that people are going to be able to make self-referrals for, doesn't undermine the severity of your condition. You don't necessarily need to see the GP. It's actually quite a liberating thing, and knowing that that's been developed in partnership with primary care, I think is really important for the public. So this is additive to a service that is already there, and hopefully means that the GPs will be seeing that perhaps the more complex cases and those that really they are the best placed professionals to see. So I just wanted to make that point for people.
Yeah, really important. Thank you, Sarah. Nikki, please.
My perspective to add was just about the impact on the workforce of the pressures to always improve your access, see more patients, get through the door. And very often the variation in access could be about variation in demand. So some practices just have a much higher demand, and therefore it's very difficult to put on as many appointments as needed. But I think making it more complicated is, if you're in a practice where the demand is very high, you're much more likely to have a higher staff turnover, and then have teams that are embedded, you know, to make those changes over the longer term for the practice. So when we're sort of addressing this variation, I think we very much need a plan of how you're actually going to support those practices, support the people in them to, you know, look at a long-term view, but also stay in the practice for a long time, even though the demands are higher, because it's not a level playing field as far as kind of demand on practices go. And also just focusing on the number, you know, how many appointments or how easy it is to get an appointment doesn't necessarily tell you about how safe those appointments are. You know, is it safe to have an appointment that only lasts 2 minutes because it's the 50th appointment of the day, versus safe working levels for the clinicians to offer longer appointments that actually deal with all of the problems the patients come with. So I think it's a lot more than just the number of appointments offered. And I think, you know, if we talk about this levelling up, how do we actually support that levelling up for those that are struggling, and support the clinicians to deliver safe services as well as the numbers?
Nikki, thank you. I think that probably goes back a little bit to what Nigel was saying sort of earlier when we were talking about, you know, the quality and the time that you might need with some patients as well, and that might drive variation to a degree as well. So I guess that's all the challenges in using these sort of very black and white measures. I think that there are a number of comments still to come, so I'll take those, and then we'll probably need to pause there. But I think Will was next.
So yeah, I mean, just taking on board what everyone else said, I think this is probably the biggest change in how we deliver general practice, I think, probably ever. So I would agree that engagement with patients is going to be absolutely key with us. The other thing I really wanted to highlight out of this, because a lot of what we talked about is access, is that primary care, secondary care interface work that's been done, and there's a big section here about this. So the team has been really doing a lot of work around this. Now there are four asks nationally in this space. We think we can go much further than that, and we have been going much further than that, and trying to really improve the relationships between the clinicians and those clinical interfaces between primary and secondary care. That is absolutely key to developing that collaborative way of working. We feel is necessary to improve patient outcomes. So I just want to highlight that and just commend the team that's been doing it. They've done a fantastic piece of work around sort of semi-structured interviews to really get to the bottom of that, and also really looking at what is working well in our system. And I'd like to say to the Hereford end, Nigel and team, those are things like the Transformation Tuesdays and your safety and sync have been real points of learning from us. So there are some really bits of excellence in our system around that primary secondary care interface I'd just like to pull out of this.
Thank you very much, Will. Really good to note that. David Whiteman, please.
Thanks, Krishni. Again, like everybody else, I really welcome the paper and the clear plans, and that's really great. Just have one question about, do we have to accept that there are limits as to how much we can influence individual GP practices? Is that something we have to accept as an ICB?
I don't. Oh, sorry.
Go on, Linda.
Sorry. No. I don't think that is acceptable at all, David. We've got the existing approach prior to the support that's available nationally and locally, which was around having that face-to-face discussion about managing variation. And now within this plan, there is much more available to practices and the ICB to say, here's an offer that will help you address some of those challenges and pressures that Dr. Berger has quite rightly pointed out. And I hope you'll see, coming back to Sarah's point, within the plan, our local ambition and aspiration very much recognises that the size of some of our practices, the rurality, means that this isn't as simple as finding some GP somewhere who will come into the practice and work. This is about looking innovatively at digital and other methods of working. Nigel's point about smarter working, and that's how we get to the heart of variation. And the PCN plans that have been submitted help us understand and shine a light more than ever before on those practices that we need another conversation with.
Okay, thank you.
Thank you very much, Linda. Final comment from Nigel.
Yeah, I just want to say that I think there's great value also in the peer support that you can have from primary care working at scale. And I think actually there's nothing more powerful to motivate change